Well,
Good afternoon, everyone. It is 3 o'clock, and in the interest of making sure we make the best use of this hour, we're going to start on time. My name is Kara Kumari, and I am the Assistant Commissioner for DIDD for Communications and External Affairs, and we are very excited to have you all joining us today. I am going to share my screen, and we will get started in just a second. So if you will just give me a moment to share my screen. Great. You should all be able to see our presentation now. Once again, my name is Kara Kumari. I'm the Assistant Commissioner for Communications and External Affairs for the department. We are so glad to have you all on today with us. How we're going to do this is we're going to provide a brief presentation, or a not so brief presentation. That should take up about 30 minutes of our time. And then we really want to leave the last part of this for questions and answers, so that people who have questions can answer them. I know there are several DIDD employees as well as providers who are on this call. My only request would be that I really want to make sure that the families and people supported who are on this call have an opportunity to ask questions, since this is a program targeted to them. So if those others could allow families and people supported to ask the questions during the time we have for questions, that would be very much appreciated. We're always available on Wednesday mornings during office hours to answer any IDD program integration questions for the stakeholder community at large. We are going to get started. And the first thing we're going to do, I will remind everyone to mute your phones, and we have the chat box open for questions. So please feel free to insert your questions into the chat box, and we will get to them after we are done presenting. We would really encourage everyone to listen to the presentation because your question might be answered in it. But first, we're going to start. We have Commissioner Brad Turner on with us today, and I am going to turn it over to him to give us a few words about what this means and why we're wanting to be able to provide you all with this information today. Commissioner Turner.
Thanks, Kara. Good afternoon, everyone. I certainly appreciate you joining us on a busy Thursday. I know that you've got a lot going on in your own lives, but I appreciate you taking some time out to talk to us so we can walk through some of what we're working on. And we certainly want to make sure that there's feedback that you can provide to us that will help us continue to build a world-class program that we're all proud of. Just a couple of quick introductions about myself, and I want everyone to be able to know this. First and foremost, I'm the parent of a child with intellectual developmental disabilities. My daughter's name is Kinsley. She has cerebral palsy. She's nonverbal. She's in a wheelchair. She has several global delays, epilepsy. So every day when I come to work, I want you to know that the first hat I always put on and the last hat I always take off is one of a parent. And I know in our world that change can be a very scary thing. It can be unpredictable. It can be less than reassuring. But I want you to know that I'm in your corner. I'm sitting in the same chair that you sit in as a parent, as a caregiver, as an individual supported. It's important to me that you know that. And I recognize that trust is built on credibility only, but credibility can be built on proving yourselves by showing that you are putting the needs of others above the needs of yourself. And I want you to know that that's what we're committed to doing. We've got an extremely good relationship with our friends at TennCare as we work together to navigate some of what these challenges look like. And I know there's a lot on your plate right now, and I can empathize with that. But I want you to know that your voice is extremely important to us. We want to partner with you. We need to partner with you as we create something as robust and as big as what we're working on. It's important that we hear from you. And I want you to know that I'm committed as the commissioner of this department to make sure that I not only listen to you, but we actually hear what you're saying, because those are two very different things. We want to take your advice. We want to take the input that you have. In many ways, You're the visibility in our blind spots, areas that we might not see, that you're aware of. We want you to contribute and share with us, because that's what it's all about. At the end of the day, as parents, I know for myself that there's very few bigger fears in my life than what's going to happen to my daughter when I'm not around, or what does her future look like. And their future, and the way that we see it as parents, is very different than the way some of our friends look at the future of their children. And I want to commit to you that there is absolutely no way that I would ever endorse the creation of a system that didn't allow your child or my daughter Kinsley to continue to be exceptional and reach their ability in whatever manner that looks like that God has given each one of them. That's the type of program that we want to continue to build to allow them to thrive and develop and be the best that they can be. So as we're navigating this, I do ask that you share with us the same level of patience and grace and mercy that I think the world sorely needs right now, because we're going to have some, you're going to have some questions that we might not have answers to right away, but I can promise you that we want to hear those questions so we can get you those answers. I know the Bible talks about too much is given, much is required, and much is expected. And we've been given an incredible opportunity here to develop a new system that's going to allow more individuals to be served in a more effective manner, that allows them to reach whatever goals they have in their own lives. And we've talked about this a lot, and I'll close with this. We want to build a system that tells your loved one and the person that you care about everything that they can do, and not build a system that tells them everything they can't do. That's not what we're about here. We're about being exceptional. We're about reaching potential. We're about opening doors and creating new opportunities for employment, for community engagement, and for success for individuals. So thank you again for joining us this afternoon. Please don't hesitate to ask us questions in the chat box, or any of your points of contact can certainly get to us. We're committed to listening to you. We're committed to partnering with you, and we're committed to make sure that you feel like at the end of the day that not only have you had your voices heard, but you feel like you're a partner in this process, because that's what we want overall. Thanks, everyone. Kara?
Thank you, Commissioner, and thank you also every day for your leadership in not only your concern and care for the people with disabilities, but also for your employees as well. Okay, today we're going to have a couple of people who are going to be on here that will be presenting and also answering some of those questions and answers. So I wanted to go over, I've already introduced myself, and you can either see my office in the camera, or you can see my picture on the screen. Also, we have Jordan Allen, DIDD Deputy Commissioner of Program Operations, joining us today. And we have Patty Killingsworth, who is a 10 Care Assistant Commissioner and Chief of Long-Term Services and Supports. Those two are working every single day to make this the best program that it can possibly be for people in Tennessee with intellectual and developmental disabilities. So over the course of the next half hour or so, we're going to talk about a few things. First of all, we're going to talk about this new program. And some of you have heard us talking about this single seamless system of service delivery. But what that really is an idea about how to make services better for people in Tennessee who have intellectual and developmental disabilities, whether they are in services, whether they're waiting for services, or whether they do not even think they need services right now, but they might need them in the future. Also, we're going to talk about, what does this mean to you? What does this mean to you as a person either in one of the programs in Tennessee, or what does this mean to you as the conservator or family member of a person receiving services? And finally, we'll talk about those next steps. We kind of wanted to start by going over a few of the words you're going to hear and some of the phrases we talk about. One of those things I heard very early on when we started receiving some of the initial family feedback was that we oftentimes use too many words and jargon that people don't understand what that means. So hopefully we can break it down today in a way that is more understandable, more digestible, and really helps people really understand the concepts we're talking about when we talk about a single system. First, we're going to talk about long-term services and supports. And if you have an intellectual or developmental disability and you live here in Tennessee, these are some of the programs that can help you live, work, and play in the community. Sometimes they're called home and community-based services because the goal of these services is to make sure that a person receives the support they need, not in an institution, but within their homes and the communities which they live in. Also, like it says, these programs are called long-term services and supports, and sometimes we also call them LTSS. So there are three different types of programs in Tennessee, these LTSS programs that help people live, work, and play in their communities for people with intellectual and developmental disabilities, and also provide care for people with disabilities. The first are called the 1915C waivers. Sometimes these are called the DIDD waivers. There are three of them. One is called the statewide waiver, one is called the CAC waiver, and there is another waiver called the self-determination waiver. Right now, those waivers are often, they are administered through DIDD, or DIDD has oversight of these waivers, and those services are provided by community-based providers. There's also a different type of program, and this is the newer program for people with disabilities, and it's called the Employment and Community First Choices Program. This program also utilizes community-based providers to help people with intellectual and developmental disabilities live, work, and play in their communities. And finally, we have intermediate care facilities for individuals with intellectual and developmental disabilities. And these are called ICF IIDs. And these are oftentimes, but not always, smaller residential settings that are intended to provide care for those who have complex medical and or behavioral needs. So we're talking about three different programs here and three completely different systems. And right now, all three of these programs have those different structures. They have different names, different types of things, different services. Not every program offers the same menu of services. And they also have many, many different processes. However, all three of these programs serve the intellectual and developmental disabilities population. So we have three programs, three different systems with three completely different structures that are all serving the same population. So not only, as you can imagine, providing services to the same population in three different ways oftentimes provides for some confusion and also does not always have those services as coordinated as they can be. So sometimes your medical services, behavioral services, and those long-term services and supports, they don't work together in all of the programs. What happens is you have one group responsible for a certain set of your services, and then another group responsible for a different set of your services. And the right hand is not always talking to the left hand in those situations. So that's one of the things we're seeing right now, the way things are currently structured in those three different systems. Another thing we're currently seeing right now is with our budget. Right now, we know that more than 5,000 people across the state of Tennessee are waiting for services. They would like to receive those long-term services and supports, but they're not available to them yet. That's because we can only serve as many people as we have the money to pay for. And this year, there's no money for people to enroll in services. We had hoped that we were going to be able to enroll more people into services, but because of the COVID-19 public health emergency, we have, the state is experiencing some budget challenges. And what that means is we are not able to enroll new people into those services. And it also means that the budget and the amount of money we have to be able to provide certain services to more people might not be available for several years to come. So we found ourselves at a place. We know that we have three different structures and three different systems that aren't operating as effectively as they could. We know we have budget challenges, and we know there are some hard decisions that could be needed in the future. But what we also knew is that there was a chance where we could make a bold change that would really help us in all of those areas. And that's where that idea came from, a single system. So how is a single system really going to benefit everyone in Tennessee? Not only those in services, but those waiting in services. First of all, if all three programs work together, it could help more people in Tennessee get the services they need. Obviously, when different programs are requiring different things, it takes more people to do those things. If one provider, for instance, has to fill out 4 different forms for 4 different companies in 3 different systems, that's going to take a lot of time, as opposed to that one person filling out one form. So there are so many ways where we can really streamline those systems and really make people not have to concentrate on those tasks, those redundant tasks, but allow them to focus more on what we really want people to focus on, which is the providing of high quality services to the people we support. Also, in 3 different systems, we talked about they have 3 different structures, and they have 3 different types of services for the same group of people. If we had a single system, everyone in the programs could have the same opportunities that for working, using technology, and also to advocate for themselves. Right now, what we see is that some of these different programs do one thing very well, but that opportunity for the same population in a different program isn't being extended to them. And that's not because anyone's trying to keep those services away from people. It's just because of the way that the different programs have been structured. It's just not always has it been structured in a way that allows certain people to have easy access to some important services. So those are the reasons why we're looking at a single system. How would it work? First of all, here are the important things you would need to know. DIDD would be in charge of all of the programs. What this means is that DIDD, the state agency that is responsible for providing services and supports and overseeing services and supports, would have that oversight and leadership of all 3 of the programs, not just those quote-unquote DIDD waivers. So how are we going to do that? We're going to use managed care to do that. What that means is that health plans will contract with providers for services. That's right now how things work in the DID, quote-unquote DIDD waivers. Right now, that health plan, Blue Care, AmeriGroup, United Healthcare, they're providing those behavioral and medical services for people in the DIDD waivers. And then DIDD has had oversight for those home and community-based long-term services and supports. Now, under this, all of those services would be contracted through the managed care organizations. And one of the reasons we're doing this is because it would help those services, those long-term services and supports, those medical services and those behavioral services, those services that don't always work well together right now, where the right hand and the left hand often aren't talking to each other. This will help them work better together and really improve a person's quality of life and overall experience with health, safety, and being able to live, work, and play in their communities. So as I mentioned, the managed care health plans, these are the 3 that are in Tennessee: AmeriGroup, Blue Care, and United Healthcare. And if you are already in a waiver program, either Employment and Community First Choices or the 1915C waivers, those DIDD waivers, or an intermediate care facility, you already have a health plan that is helping you with your medical and behavioral services. And also in the instance of Employment and Community First Choices, they are already helping you with your long-term services and supports. And if you have Medicaid, you can find out which of those health plans you're working with by looking at your insurance card. So what does a single system mean for me? Let's talk about that. First of all, the services and supports you need will stay the same. And the way your services are provided or paid for, they may change to make sure that all of the programs are working together. And we'll talk a little bit more about this in just a while, and we're happy to answer questions for this as well. And what this also means to you is what we're going to do we're not going to do in the dark. You are going to be able to see any of the changes that we are proposing to the way that services are paid or the way that services are operated before we make them. And you're going to be able to tell us what you think about those. We are required to have a public comment period before we submit those changes to the federal government. And at that time, you are able to really not only tell us what you think, but we look at all of that input. And I can tell you that I can't think of a single time since I've been at DIDD that we haven't seen things in public comment. One of the things that Commissioner Turner said is you guys can be our blind spots. And I think 100% of the time, we have found things in public comment and added them to the proposal before we submitted to the federal government because of the things that you saw, because you are our blind spots. Also, if you're looking for updates and you want to know what's going on, you can always look at DIDD's Open Line newsletter. And if you are not on that, Carly will leave her email address in the chat box, and you can contact her to get registered for Open Line and receive those updates, which we do on a weekly basis. Right now, we're going to go over some of the key terms in the proposal. First of all, what does managed care mean for me? First of all, managed care is a way for the state of Tennessee to pay you for your services. And this is not a new idea. Most states use managed care to pay for managed Medicaid services. And in Tennessee, we've been using managed care for a very long time. In fact, all of Medicaid services, except for those 1915C DIDD waivers and the intermediate care facilities, are in that managed care program model. So this is not something that is new to Tennessee. And Tennessee has had much success using this model for many, many years, including for people with intellectual and developmental disabilities through that Employment and Community First Choices program. So in this new proposal, managed care would pay for services in those 1915C waivers and also in the intermediate care facilities. And DIDD would take over the administrative oversight of all long-term service and support programs for those people with intellectual and developmental disabilities. So for the first time, this means that the funding, the model, and the oversight for all programs for people with intellectual and developmental disabilities would be the same in the state of Tennessee. What does DIDD oversight mean for me? Because what's going to happen is while people who have been in those 1915C DIDD waivers have had that DIDD oversight, two new programs, Employment and Community First Choices and the ICF IIDs, will be having that DIDD oversight for the first time. First of all, DIDD has been involved in these programs, both of them, for a while through doing different things. But now DIDD will be in charge of some of the same things, how you get into services. It's called intake. And right now, that's something that DIDD does for a portion of folks in the Employment and Community First Choices program. Also, they would be in charge of what the services are like and also how much support you get. So that service planning and authorization, we would have oversight of that service planning and authorization. How your provider is doing, that's called quality assurance, and DIDD has long been involved in that in all of the programs, and also helping you if there is an emergency, also called critical incident management. And DIDD, once again, has been involved in doing that for a very long time. Like it says, DIDD is already in charge of many of these things, but having DIDD in charge of everything is going to really make things less confusing for you, your family, and your provider. And also, DIDD has many employees who have been working for many years with this population. And there's expertise, there are experts in many areas, enabling technology, employment, operations, person-centered planning, communications, all of these different areas where that experience and expertise, which has always been dedicated primarily to one program, will now extend over all three programs. And we're very excited about the ability to do that. So what did the changes, the ICF IID changes, mean for me? First of all, the IDD will help with training and supporting your staff and providers. So we will be having the training and supporting of staff and providers in ICF IIDs. Also, DIDD will work with providers to update how the state decides who should live in an ICF IID. That's often called admission criteria. As I mentioned earlier, the ICF IID model is intended to serve people with those who have high levels of medical or behavioral needs. And once again, this ICF IID program is the smallest of the 3 programs. So it will now be managed with other services for people with IDD. So what would a new system be like? A new system will focus on a person's goals. The person and their goals and outcomes will be the main focus of what services and supports they receive. And that's how it always should have been. And we really want to make sure that we're designing a program that really helps a person achieve their outcomes. Like it says, make sure everyone who works with you celebrates your accomplishments. So everyone wins when you do. Commissioner Turner likes to say and likes to tell us all that we need to celebrate our wins. And that also extends to people in services as well. And we want to make sure that services not only give people the opportunity to have those wins, but everybody is supporting them and celebrating those wins when they make them. Also, a new system will honor your ideas and suggestions. A new system is also going to do a better job telling you more about what services you get and what they are like. One of the things that's going to be very important in the new program is something called person-centered planning. And person-centered planning is not only about making sure the person is at the center of everything we do, it's also about making sure that the person and those around them understand all of the options that are available to them and how those options might support them to achieve their goals. So one of the things that will be very important is making sure that all of the people who are helping that person make those decisions and those teams make those decisions understand what's out there. And that comes through training and education. And those are things that we're intending to do to help make better plans for people that really help them achieve their goals. Also, a new system will do more to show you how enabling technology can make a difference in your life. One of the things we've seen is that many people think that the only reason a person has enabling technology is to live alone, and that's not the case. Independence is different for every single person. For one person, it could be living alone, and for many people in our services, they want to live independently. However, there are so many people in our services that independence means they can drive their power wheelchair with their eyes using enabling technology. Or they can finally open the door when they have a visitor using an app. So independence and enabling technology can support many people in many different ways. And independence is something different to every single person. And what we want to do in this single system is honor that and ensure people understand how enabling technology can help them. Also, a new system will help your staff, also known as direct support professionals, stay in their jobs. I'm sure that many families, many people supported know that staff oftentimes do not stay in their jobs. And staff turnover and having different staff working with people can sometimes lead to behaviors. It can keep that person from forming those connections with their staff, and also cause them to not be able to meet their goals and outcomes as quickly as they'd like, because if a person helps them and then leaves and a new person has to be trained on how they like to be supported, that can be a very lengthy process and also cause some setbacks. One of the ways we're going to do some of this stuff is called value-based reimbursement. And a lot of people ask, well, what does that mean? To break it down in some pretty simple terms, first of all, what it means is that your providers could be paid more money if they deliver great services to you. So if services are targeted and high quality, your provider will get more money. Those services should be helping you achieve your goals and outcomes. Your providers could also be paid more, like it says, for helping you with your goals, like having more control over your life and having a job you love. We want to make sure that people are able to experience the lives of their choosing and also learn more about what employment could look like and what self-advocacy, what being able to speak up and exercise their rights looks like. These are the kinds of things that are called value-based reimbursement and what we mean when we talk about value-based reimbursement. So those are some of the key terms in the proposal. And I've already seen a little of the chat box conversation going on about some things that some concerns people have and some things that people are worried about. And so we really wanted to talk about this, myth busting. What's true, what's not, what's fact, what's fiction. And we want to hopefully be able to put some people's minds at ease over some of the things they've heard. The first one, and the one that I've already seen in the chat box, is that your ISC or case manager or support coordinator, that person is not going away. So your ISC, case manager, or support coordinator is not going away. When we talk about what an ISC, case manager, or support coordinator is, this is the person who helps you coordinate your services and supports plan. They are not going to go away. And as we talked about, if you are in if you are in the statewide and the CAC waiver, you have an independent support coordinator. If you're in the SD waiver, you have a case manager, and you have support coordinators for the Employment and Community First Choices program. Once again, 3 different systems, 3 different names for the person who helps you plan your services. So what are we going to do? DIDD and TennCare are going to take at least a year to look at each of those 3 different systems of providing support plannings before deciding which one to use. We really want to make sure that all those systems, that what is really happening is that support plan is helping a person achieve their goals and outcomes. Because that's the thing that's most important, is are those plans person-centered? Are those plans really putting the person first? And are those plans really helping that person achieve the goals and the lives they want to envision for themselves? The way you get help with your services will be the same, no matter who is providing the support. So that's an important thing. Your ISC, case manager, or support coordinator is not going away. And we are really looking to make sure, looking at all 3 of the different models that exist, to make sure we are looking to see how to best provide support to the person and make sure those support plans are helping people. Here's another myth, and here's the truth. You will keep getting the services you need. So after these changes, you will keep the same services you have now. In fact, DIDD and the managed care health plans are going to work together to make sure you get the services you need. And if you are denied a service you need, you can appeal just like you can today. So many things are not changing when it comes to the services and supports and what is happening and how you can appeal them. You will not have to change providers. Another thing that we've heard people fear. Managed care organizations are going to contract with all current waiver providers for at least the first 6 months. So on day 1, your provider is not changing. Your provider is not going away. So nothing will change with your current provider. And DIDD will help your providers stay in the system. One thing that's really important is that DIDD is going to be working with all providers to make sure that they can provide services that help you meet your goals or help your loved one meet your goals. And we expect that most providers are going to continue to want to provide services in the new system. But if you ever want to or need to switch to a new provider because they are not able to meet your goals, DIDD or your MCO, really DIDD and your MCO will help you make that switch. Another myth, and here's the truth. Employment first does not mean you have to work. And this is one we've heard a lot over the past couple of months. As you may have opportunities for things like working and using technology, you do not have to work or do anything else you don't want to. However, I do want to talk a little bit about employment first. The IDD is what's called an employment first state, which means that we believe that employment should be the first and preferred option. Competitive, integrated employment, working at a job in the community for minimum wage or higher should be the first and preferred option for people with disabilities. But we want to make sure that people who say they don't want to work really know what work means and really have had the opportunities to explore what work looks like before they say no. And then people can still say no. They can say, absolutely, I do not, after they review everything and we say, here's what a job looks like, here are the benefits from having a job, they can still say, no, I don't want to work, and nobody is going to force them to work. Another myth, enabling technology will not replace your staff. If you choose to try enabling technology, you can still get support from staff. Enabling technology, as I mentioned a little while ago, means different things. It can mean sensors in your bed to alert someone that's nearby if they want to, if you have an issue. It can mean controlling your wheelchair with your eyes. It can mean an app on your phone that can help you use the bus to get to work. Or it can mean, if you're at your job, having an application on an iPad to provide job coaching and prompts while you're doing your job. So enabling technology is not one size fits all, and it doesn't mean there's only one type of way to provide that support. As it says here, enabling technology means you can use technology for help if you want to. And if you are using enabling technology, staff is always close by in case the technology fails. For people who are using enabling technology to live more independently, there is always a backup plan. And staff are never far away. They are within single-digit minutes away if something happens and the technology does not work. And you can see on this picture, that's actually from one of our videos of Brad, who now lives independently utilizing enabling technology. Another thing, natural supports. When we say natural supports, what we mean is that they are a part of your team. Natural supports are a part of the friendships and connections that people have with people we know and care about, families, neighbors, and coworkers. That's what we mean when we say natural supports. Those are the people who are in your circle. And if you've ever done something for someone else without asking them to pay you for it, you've provided a natural support. So natural supports are all around us and are being used everywhere. And when we say we want to use natural supports, it doesn't mean we are going to start expecting family or friends to do things they don't want to do. Services should help people develop relationships with other people. And also, they shouldn't get in the way of people spending time together or doing things for each other. Sometimes the way that services are structured right now, it makes it hard for people to make friends, or it makes it hard for them to develop natural support, because there's always, oftentimes there's always someone with them, a paid support doing something for them. And sometimes that gets in the way of them making new friends or being able to have people that will that are a part of their lives, that make their lives better. A single system is for people with all kinds of needs. One of the things we've heard is people are concerned that this single system is only going to be for people who can work or have technology, and that is not the truth. The single system is for people with all kinds of needs, and this includes people who have high level of support needs, extreme medical and behavioral complexities. These are people who will be successfully supported in the single system. And quality and safety will continue to be one of our most important goals, as it has been for years. So in the interest of time, we're going to go to what happens next. First of all, I talked about how important that feedback is. The feedback right now is the most important part of this process. One of the reasons we're having this presentation today is because we received feedback that people did not understand our last two presentations, and that it was intimidating and people weren't able to really get the information or ask the questions they wanted to. So that's how feedback can make an immediate difference. And we're asking you all to send your ideas to before August 28th, 2020. And you can also go to the following website and get more information. So after we send in that feedback, DIDD and TennCare will look at all of the feedback and will develop the plan and make changes to the plan. And all of those changes, as I said, will be posted online so you can see them. We are hoping right now that we can post the plan for that public comment period so you all can review and tell us what you think by fall of 2020. Once we get that public comment, make any changes we see we need to make to it, we will get it ready and submit it to the federal government for approval. That all has to happen before we can start making the changes in Tennessee. And we're hoping to have that approval by July 1, 2021. Okay, so now I think I took about 35 minutes, so I really want to make sure that we have time for those questions. So I will stop sharing and start going through the chat box and answering some of the and seeing some of the questions that are here. Okay, I think we talked about the first one. Would the new system remove ISCs for persons supported? And I think we've discussed that already. No, a new system. We are going to be talking, and people will not lose their ISC case manager or support coordinator, and that we would be reviewing those for at least a year. Can I get a copy of the material presented here? We are recording this, and we are also going to post this presentation on that IDD integration page, and it will all be available there. So who would decide how much of support a person gets, DIDD or the MCO? We've got Patty Killingsworth on here, and Patty, would you like to take that question?
Sure. Well, I think the most important group that helps decide what a person needs is their own circle of support, right? That's a process that's in place today. And the way that we envision that this will work in the future is that once that circle of support working with the ISC has developed that plan of care, then that would be reviewed by the managed care organization. But importantly, as Kara talked about earlier, DIDD is going to continue to oversee that process. And I think in particular, DIDD will probably be very attuned to any reductions or denials in service, just to make sure that those plans are being reviewed appropriately and that people are getting what they need.
All right, thank you very much. Will the PA position still exist? Jordan Allen, our Deputy Commissioner, would you like to talk about that?
Sure, thanks, Kara, and good afternoon, everybody. So, yeah, as we stated in the beginning of the presentation, PA services, like the other services people are receiving now, will continue to be part of the benefit package. And as Patty was just indicating, it's really the underpinning or the foundational component of any of the changes that we plan to make in, by 7/21 or thereafter will be based on the fact that we want to give families and people supported the ultimate authority to decide what services you receive and then ultimately how you receive those services. And what we intend to do is support the provider network and pay for the achievement of outcomes. You as family members and people supported decide what it is that you want to achieve, and then our goal is to put the supports around people to achieve their outcomes.
The next question I'm going to take the next two questions together just because I think Patty will answer both of them, and they're about the role of MCOs. What role will the MCO play now, and will the MCOs have a financial incentive to deny or reduce services?
Sure, happy to talk about that. So, Kara, I think you've done a really good job of laying out some of the really important things that MCOs can bring to this process. One of those is really helping to make sure that we are looking holistically at each person's needs and that their physical health needs and their behavioral health needs, as well as their long-term services and supports needs, are all being met. It's one of the greatest values that they'll bring. As we think about sort of the 7/1 launch, There's probably more from a 1915C perspective that will look the same than there is different. Certainly MCOs will begin to pay providers for the services that they provide. And as we talked about earlier, MCOs will look at plans of care and review those. But there's a lot of things about the current system that will stay exactly as they are today. We talked about independent support coordination, you continuing to work with your independent support coordinator and with your circle of support to develop your plan of care, all of that. The issue of incentives is complicated, and I don't want to take too much time with it because I know there are a lot of questions, but I want to be sure I answer this in a way that people really can understand. There are lots of different ways to pay managed care organizations. I think we're getting a little bit of feedback. If somebody doesn't mind to put their phone on mute, please. I think there's another conversation maybe happening. So I think the person who asked the question is probably concerned that we will pay MCOs using what's called a capitation payment or a risk-based arrangement, where that basically means that a managed care organization is paid a fee that is intended to encompass all of the services that that person receives. It feels like, or there's a risk that there's an incentive for that managed care organization to provide less service because then they get to keep the money, if you will, in a risk-based arrangement. But there are lots of different ways to pay managed care organizations. There are non-risk-based arrangements called ASO models. There are also modified risk arrangements where money that might not be spent on medical services comes back to the state to provide more services. But more importantly, and we haven't decided honestly how we're going to pay the managed care organizations. That's something that we're still looking at. We're looking at how other states do it for this population. By the way, people in employment and community first choices are not in a risk-based arrangement. That's not how we pay managed care organizations for those services today. But the main thing I want you to hear is that no matter how we pay them, we will have checks and balances built into the system. We've already talked about that, where we expect that DIDD will oversee those decisions and in particular oversee denial decisions to make sure that those are appropriate. I'll also say that when we implemented the Choices program for older adults and people with physical disabilities, and we moved waiver programs into managed care, that people had the same fears and concerns. And we're now 10 years into that program, and I'll tell you that in those 10 years, not only have we seen managed care organizations not take services away from people, we've actually seen them provide more services to help people stay in the community, and we've built incentives into their contract for that to want to happen, for them to make sure that people receive the supports that they need to stay in the community so that they don't need to go into an institutional setting. So just know that that's important to us. We understand your concerns, and we'll make sure that no matter how we do that, that there are protections in place to make sure that people get what they need.
Great. Patty, I'm going to call on you again. Will medical necessity be used to determine eligibility?
Great question. So medical eligibility or eligibility for services called level of care is already based on medical necessity, if you will. There is every state is required to establish criteria that would qualify a person to receive services in an institution. Those same criteria are applied to people who are enrolled in these 1915C waivers and in employment and community first choices, by the way. And those are medical necessity criteria. They are criteria about whether a person's level of need would otherwise require them to be served in an institution. Right now, we're not thinking about changes in those criteria. I think we'll always continue to look at that to make sure that we're making the right decisions for people, but just know that that's a part of how eligibility for services is looked at today. Also know that we don't intend to do anything that is going to make anybody who's eligible for these waiver programs today not eligible for these programs tomorrow.
Thanks, Patty. And then Jordan, for the next one, we've got two questions. Who decides what constitutes delivering great services, and how are great services determined for providers to get more money? Jordan, do you want to speak a little bit more about what we mean when we talk about value-based reimbursement and how providers will be incentivized to deliver those great services?
Sure, and great questions. So that's, again, kind of at the root of that, it's fairly simple in that our overarching goal is to make sure that people are achieving their desired life and given the tools to achieve outcomes that help them reach that point. And so when you ask how we'll determine what quality service looks like, I would say that the primary determination is, are people living the life that they want to live? Are provider agencies, is the system supporting people to achieve the things that they identify as important for themselves? And so, you know, the beginning of that certainly is the development of the plan. We're pouring in a tremendous amount of time and resource to ensure that there is alignment on how a quality plan is produced across each of the waiver programs. In fact, we're engaged right now with the managed care organizations and the department and our own case managers on developing a single system for planning. And then probably even more importantly are the outcomes that are derived from that planning process. And so quality for us is quality for you. And if people are achieving the goals that they set for themselves, if the case managers, the ISC and the provider agencies are equipping people and families with the knowledge and the information they need to make good informed decisions about the tools that are available to them to help them reach those goals, then it's fairly easy to determine whether or not those goals are achieved. So at the root of a value-based payment approach will be, are people ultimately achieving the goals that they set for themselves? And in the event that they are, certainly provider agencies, case managers should be rewarded for that. And in the event that they aren't, that gives us a cue that either the planning and outcome process continues to need work, or the tools available to people to achieve those goals aren't working as efficiently as possible. Either way, it allows us to kind of target training and assistance to the area that isn't performing the way we want it to.
Thank you, Jordan. And we got several questions, and I'm going to call on Patty to answer them, about where is the extra money coming from that is going to serve people off the waiting list. We got several different versions of what that means, whether that means services are cut or whether or not, or how this will allow for people to receive, more people to receive services. So Patty, would you like to take that question?
Sure. I think that's always everyone's greatest fear, right? Is that services are going to be reduced, and that's the only way that we're going to be able to provide services to more people. I think there's a couple of ways that we envision that there's the potential for some funding to be able to serve people from the waiting list. One is that we've talked about the challenges that providers have in operating in multiple programs or multiple systems. An example of that would be that today, if you want to sign up to provide services in employment and community first choices and in the 1915C waivers, you go through 4 enrollment or credentialing processes with 4 different entities, one with the IDD, one with each of the managed care organizations. If you want to bill for services in those programs, you are going to bill 3 different managed care organizations and the IDD. If we can consolidate a lot of those processes and really simplify them, then we can reduce some of the expense that providers currently incur in delivering services across all of those programs. If you've been around for a while, you know that the state was involved pretty heavily in federal litigation for a long time related to the developmental centers. And sometimes litigation has negative unintended consequences. One of those was really to drive some things in the system that caused it to cost more for providers to deliver services. And so when we talk about really moving toward a person-centered system, part of the changes that we want to make is to try to get back to the way that services should be provided and not have some of those really restrictive requirements in place that resulted from some of that litigation. The other thing, and we've talked about this, is that for some people, enabling technology will allow them greater independence. And the story, Kara, the picture that you showed, and the other examples that are on DIDD's website, by the way, TennCare has some examples on our own, of people who've really progressed through a continuum of services and are now living much more independent lives than they were before. That won't be true for every person in the program. Not everybody is going to get to a place where they're living independently or even where their services are reduced much, but everybody probably has some opportunity to leverage technology to give them some more level of independence in their life. But for some of those people who progress further, that will allow additional dollars to be freed up to support additional people. Please understand that's not a we're taking services away from you. That is a you don't want or need these services anymore, and those dollars begin to then be available to provide services to other people. We have literally had people disenroll themselves from employment and community first choices because they've progressed so far, in some cases from residential services all the way through, I don't want your support anymore, I'm good, I've got it, thank you very much. And wouldn't that be great if we can help more people be able to do that?
Thank you. And we do have a lot of questions in here, and we are short on time. However, there are several of the questions that are all addressing two main areas that I really want to get to before we run out of time. First is how will this change strengthen and allow for provider adequacy? People are hearing there aren't enough available providers, and they want to make sure that there is a strong provider network. Jordan, would you answer that?
In a grand scheme way, but the credentialing process, the continued refinement of the credentialing process, I think, will allow us, one, to agree across the board on those primary skills, training, and components that are necessary in order for provider agencies to deliver quality service. And we think that it has certainly the potential to stabilize the network in a greater way. There's no question that there are pockets across the state of Tennessee, just like there are pockets across every state in the nation, where it's more difficult to receive some services, and certainly closer to larger metropolitan areas, that becomes less true. I think in the grand scheme of things, what we're going to continue to do is target specific provider types and services for areas where we know there may be gaps and continue to try to fill those gaps. And I think that strengthening the core competency of the network as a whole makes the network agencies that are providing service stronger, both foundationally from a skill perspective, but probably also financially. And those two things combined, we think will continue to produce an adequate network.
Thank you, Jordan. And Patty, the next question, we've gotten several questions about how will this improve the DSP workforce shortage? Because that is a big concern to many people who either are in services or have loved ones who are in services.
It's a great question. I'm not sure there's any challenge that is greater than the one that we face with respect to the direct support workforce. And so it has to be top of mind as we think about program innovations, but also about program sustainability. The one thing about these waivers that's fundamentally different from the way that most states approach services, and that honestly the way we've approached them in employment and community first choices, is remember these these waivers, especially the two larger waivers, were designed out of federal litigation, deinstitutionalization litigation. And what that meant is that they really started with an institutional mindset of every single person requires 24/7 supports all the time, no matter what. And you could only not have 24/7 supports if you, as a part of your planning process, justified and explained why you didn't need them. Very different from the way that we typically would approach supports, where we would really start with what do you need, as opposed to a presumption that you need to be supported all the time. I think as a result of that, there are people who get more supports than they need, and this is really important, more supports than they want. There are people who are frustrated, who are angry, who experience behavioral challenges, specifically because they get no space or freedom away from paid supports being with them all the time. And that's not okay, right? We've got to figure out a better way to approach this than that. If we can right size and make sure that people really are getting the supports that they want and need, then it allows us to really stretch that direct support workforce further and make sure that we're using them in the most effective way possible. The other thing is, as we think about ways to really pay providers in value-based ways, a part of what we're thinking about is workforce, and how do we really support providers as they recruit and retain that workforce, helping them think through the practices and the payment approaches that will help them to recruit and retain that workforce over time. There's a lot of things that are going on outside of this that are also a part of our workforce efforts, and I'm happy to talk more about that at another time. But there's no question that I think we're trying to do this in a way that will really help providers and help people supported and their families as it relates to the sustainability of that workforce.
Thanks very much, Patty. I'm going to take two more questions, and we're going to go through them briefly. The first is, will we have access to our physicians we've been using for years, or will the MCO have a list of available physicians? Patty, do you want to take this one?
Yeah, sure. And really great question, and a great answer that I think will set your mind at ease is that nothing's changing, right? So you already have a managed care organization today. If you don't have Medicare as well as Medicaid, then with your managed care organization, you have a primary care provider that you already see. You're not going to change health plans. That the person who is enrolled in the waiver, nothing is changing with respect to your health plan. If you have Medicare, then your primary care is provided for you by the Medicare program. And again, nothing is changing. So you don't have to worry that there's going to be disruption in those relationships. Nothing is going to change with respect to that.
And then the last question, I'm going to turn it over to Jordan. It's I still see there are several questions about ISCs or support coordination or case management. So I'm going to have Jordan just once again discuss support coordination and that aspect.
Yeah, thanks, Kara. So your response before, I would just reiterate that your ISC or your care manager through the ECF program or your SD case manager won't be changing. What is important about what we're engaging on right now is the collective development of the process. So one of the benefits of this alignment is it gives us the opportunity to pull partners in from across the spectrum of HCBS services and find out what's working and what's not working in each different application. And that's our plan going forward. So we're bringing those groups together, ISCs included, with care managers from the managed care organizations and the DIDD case managers to determine what the most effective approach to planning, development of outcomes, and capturing someone's vision of their own desired life is. And then we want to sit back and watch how that stuff works and make adjustments along the way. We have heard time and time again, and in fact understand in a very direct way how important that care coordinator, independent support coordinator, or case manager is in the lives of people and families, and certainly they serve as an independent and predominant resource for the availability of services. And what we want to do is strengthen their role, equip them with the information that they need to best equip you as family members and people supported with the info you need to make decisions about your services. And then once that's taken place, we want to make sure they can capture that in a way and in a plan that really personifies what it is you want to accomplish, and then we want to measure that accomplishment. And so it sounds a heck of a lot simpler, I guess, than it is when you say it like that, but the truth of it is the approach is literally that simple. Let's take the experience of everybody involved doing this, come up with the very best product we can, and then measure how successful that product is.
Thank you, Jordan. We are 5 minutes over, but I want to say a couple of things. First of all, we see that there are still other questions. We are going to work on a frequently asked questions document that targets some of the questions that were asked today, and we will put that on the IDD integration page because we want to make sure that everyone's that we are able to have questions available for folks. And this is not the last time we will do this. Anytime we decide to post a plan or have that plan ready for public comment, we will hold a presentation focused, targeted towards families so that you all can hear from us and also be able to ask questions as well. So we will continue to provide these opportunities as we go through this because we really do want to be able to answer questions. We want to be able to have the conversation with families, and we're looking forward to receiving your input. Once again, we're trying to get some feedback in by August 28th. We hope this presentation has helped you, and you can provide those comments on that IDD integration page. So with that, we are going to wrap up. Thank you, Commissioner Turner. Thank you, Deputy Commissioner Jordan Allen, and thank you, Assistant Commissioner Patty Killingsworth, for joining today. And I hope you all were able to be able to understand a little bit more, learn a little bit more about the program, and hopefully we've been able to address some of the concerns you may have had. We thank you for joining us today. Bye.
Take care, everybody.
Thank you, dear. You're welcome. And you all have